Survival with congenital heart disease now extends well into adulthood, but this journey begins in the neonatal intensive care setting. In the first days, stabilization and timely interventions prevent circulatory collapse and protect the brain. Neurodevelopmental outcomes are strongly influenced by the adequacy of early perfusion and oxygen delivery. The neonatal period therefore establishes the physiologic baseline upon which all later progress depends. As children grow, surgical strategies shift towards staged repairs or palliative procedures. Nutrition and growth monitoring are essential since poor somatic growth in infancy predicts later neurodevelopmental delay. School-aged survivors often demonstrate what is termed the neurodevelopmental signature of complex heart disease: subtle but persistent deficits in executive function, motor skills, and attention. These challenges highlight the need for ongoing developmental surveillance and support. Adolescence brings new complexity. Beyond continued medical management, families must navigate transition to adult care. Psychosocial adjustment is often difficult, with higher rates of anxiety, depression, and school difficulties reported in cohorts of adolescents with hypoplastic left heart syndrome and transposition of the great arteries. Transition planning is therefore a critical element of care. In adulthood, the focus shifts toward acquired complications such as arrhythmias, ventricular dysfunction, thromboembolic risk, and pregnancy-related concerns. Even patients considered correctively repaired may show late declines in cognitive performance and psychosocial functioning. As this population ages further, issues of advanced heart failure, organ dysfunction, and candidacy for transplantation or mechanical circulatory support become prominent. The unifying theme across this life course is that neonatal stabilization sets the stage for everything that follows. Adequate management in the NICU period directly influences neurodevelopment, growth, and functional capacity decades later. Even with excellent surgical repair, most patients with congenital heart disease face lifelong risks. Residual or recurrent lesions are common, whether due to incomplete repair, growth-related distortion, or progressive narrowing of conduits. Patients with atrial switch procedures for transposition of the great arteries, for example, often develop systemic venous baffle obstruction or leaks years later. These anatomic challenges frequently necessitate reintervention. Progressive ventricular dysfunction is another central theme. The morphologic right ventricle, used as the systemic ventricle in some repairs, eventually shows declining contractility, while even the left ventricle can deteriorate after years of volume or pressure overload. Early subclinical decline is increasingly detected on imaging, underscoring the need for serial surveillance. Arrhythmia development is a hallmark of long-term survivorship. Atrial flutter, fibrillation, and conduction disturbances are especially frequent after atrial surgery or in the Fontan circulation. These rhythm problems may appear decades after the initial intervention, reflecting scar tissue and chronic chamber dilation. Beyond congenital physiology, survivors are also predisposed to acquired cardiovascular disease. Aortic coarctation, survivors often develop systemic hypertension despite repair, while coronary artery disease and metabolic syndrome are more prevalent in adults with congenital heart disease compared with peers. These risks demand integration of preventive cardiology principles. Infective endocarditis remains a lifelong concern, especially for those with prosthetic valves, conduits, or residual defects. Even small residual shunts provide a nidus for infection. Prophylaxis guidelines, therefore, continue to apply to high-risk congenital heart disease survivors. For neonatal practitioners, recognizing these categories is critical when counseling families. Initial stabilization is only the beginning. The expectation should be for a chronic course that evolves with growth, repair, and aging. Preparing families for this trajectory helps them anticipate the need for surveillance, reintervention, and preventive care throughout life. Right ventricle to pulmonary artery conduits provide life-saving outflow in conditions such as truncus arteriosus and complex right ventricular outflow tract obstruction. However, they are not permanent solutions. The biological and synthetic materials used in these conduits are prone to progressive degeneration driven by calcification, somatic growth, and hemodynamic stress. The two major modes of failure are stenosis and regurgitation. Stenosis develops as the conduit narrows from tissue overgrowth or calcification, leading to rising right ventricular pressure and declining exercise tolerance. Regurgitation reflects valve leaflet dysfunction or annular dilation, producing chronic right ventricular volume load and progressive ventricular dilation. Both processes compromise cardiac output and eventually mandate reintervention. The expected lifespan of a conduit in children is limited. Data show that by 5 years, approximately 1/5 of patients require replacement, and virtually all conduits will fail over 1 to 2 decades. Growth further shortens functional lifespan in younger patients, since a fixed diameter graft becomes inadequate as the child grows. Thus, patients often undergo multiple replacements over their lifetime. Management centers on surveillance. Echocardiography and magnetic resonance imaging are used to track gradients, regurgitant volume, and right ventricular dimensions. Once deterioration produces clinical symptoms or measurable ventricular strain, timely replacement is indicated. Advances in transcatheter pulmonary valve implantation have reduced the burden of repeat sternotomies. But even with catheter-based strategies, the expectation remains that conduit replacement will be required multiple times over a patient's life. For neonatal providers, the key counseling point is that conduit placement is not definitive. Families should understand from the outset that serial procedures, both surgical and catheter-based, are an inevitable part of long-term care. Valve insufficiency is a frequent late problem after congenital heart surgery, and its impact accumulates over decades. Pulmonary regurgitation is classically seen after your tetralogy of fallet repair with a transannular patch. Relief of right ventricular outflow obstruction comes at the expense of valve competence, leaving the right ventricle exposed to chronic volume overload. Over time, this leads to progressive right ventricular dilation, arrhythmias, and exercise intolerance. Aortic regurgitation can follow balloon valvuloplasty for congenital aortic stenosis. Although the procedure effectively relieves obstruction, it can damage valve leaflets, leaving them thickened and insufficient. Residual or progressive regurgitation often appears years later and may necessitate repeat interventions or eventual valve replacement. Tricuspid regurgitation has its own unique associations. In Epstein anomaly, abnormal leaflet tethering and atrialization of the right ventricle predispose to significant regurgitation even after repair. Similarly, atrioventricular canal repair often leaves residual atrioventricular valve insufficiency, especially of the tricuspid or mitral components, as a long-term issue. The clinical consequences are consistent across valves: progressive chamber dilation, deterioration of systolic function, diminished exercise tolerance, and eventual heart failure. Because the course is insidious, lifelong surveillance with echocardiography and other imaging is essential. Interventions are timed not only by symptoms, but also by evidence of ventricular dysfunction, since delayed replacement carries higher risk and less recovery of function. For neonatal providers, the key counseling point is that valve regurgitation is not a static finding, but a progressive process requiring ongoing monitoring. Families should expect that valve-related issues may reemerge years after apparently successful repair, underscoring the need for uninterrupted long-term follow-up. Late obstruction of repaired outflow tracts is a well-recognized long-term challenge. After repair of coarctation of the aorta, 10 to 20% of patients develop recurrent narrowing, despite technically successful initial surgery. This risk is particularly high in infants, where vessel growth and scarring contribute to restenosis. Balloon angioplasty has become the preferred therapy for recurrence in children, though some require repeat surgery. Subaortic stenosis can emerge years after closure of a ventricular septal defect. Residual turbulence across the left ventricular outflow tract may stimulate fibrous membrane formation beneath the aortic valve. This progressive obstruction not only produces gradients, but also risks secondary aortic regurgitation and left ventricular hypertrophy. Lifelong echocardiographic follow-up is required to identify this late complication. Branch pulmonary artery stenosis is another important form, particularly after the arterial switch operation for transposition of the great arteries. Surgical manipulation of the pulmonary arteries during coronary transfer can predispose to localized narrowing, often not apparent until later childhood. Interventional catheterization with balloon or stent placement is often required to restore flow. The unifying principle is that these lesions often present years after a seemingly curative repair. Progressive obstruction produces insidious symptoms: exertional intolerance, ventricular dysfunction, or systemic hypertension. Because recurrence can be silent in early stages, structured long-term surveillance with imaging is essential for timely recognition and intervention. Arrhythmia risk in congenital heart disease increases steadily with age, largely due to surgical and structural substrates created early in life. Surgical scars are a prime factor. Atrial switch procedures such as Senning or mustard leave extensive atrial suture lines, and these regions of heterogeneous conduction become ideal reentry circuits decades later. Similarly, repeat sternotomies and multiple cannulations add further atrial scarring that fosters atrial flutter or fibrillation. Ventricular arrhythmias are frequently linked to ventriculotomy scars. In repairs that required incisions into the right ventricular outflow tract, such as early tetralogy of Fallot operations, the scar tissue creates islands of slowed conduction, predisposing to ventricular tachycardia. This risk intensifies as the ventricle dilates under chronic volume or pressure load. These substrates interact with progressive remodeling over time. Atria exposed to chronic stretch from residual shunts or valve regurgitation dilate and lose electrical uniformity. Ventricles under stress develop fibrosis, further amplifying the arrhythmogenic potential. The combination of scars and remodeling explains why arrhythmias may not emerge until years after an apparently successful repair. The clinical implication is that arrhythmia surveillance cannot be relaxed with age. The likelihood of atrial or ventricular tachyarrhythmias rises as surgical scars mature and myocardial fibrosis accumulates. Early recognition is critical, since these rhythms contribute to morbidity through syncope, sudden cardiac death, and progressive ventricular dysfunction. When the morphologic right ventricle is committed to systemic circulation, as in mustard or Senning atrial switch procedures for transposition of the great arteries, long-term decline in function is almost inevitable. These operations reroute venous return at the atrial level, leaving the right ventricle responsible for systemic output. Over years, the right ventricle, designed for low-pressure pulmonary circulation, remodels under systemic afterload stress and gradually fails. Tricuspid regurgitation is a frequent companion to systemic right ventricular dysfunction. Chronic pressure load stretches the annulus and distorts valve geometry, allowing regurgitant flow. This volume burden compounds ventricular dilation and accelerates systolic decline. Echocardiographic surveillance often reveals progressive dilation and reduced ejection before symptoms appear. Clinically, patients manifest with declining exercise capacity, fatigue, and ultimately overt heart failure. Arrhythmias, both atrial and ventricular, are common in this population, further aggravating hemodynamic instability. Unlike left ventricular failure, systemic right ventricular dysfunction has limited effective medical therapy. Standard neurohormonal blockade provides only partial benefit, and there are no disease-modifying therapies proven to halt progression. For many patients, advanced support becomes necessary in adulthood. Heart transplantation remains the definitive option once failure is refractory to medical and device-based support. Timing is critical, as delayed referral is associated with worse outcomes due to end organ dysfunction. The central teaching point is that a systemic right ventricle is not durable in the long term. Even with technically successful childhood surgery, patients require lifelong surveillance, anticipatory counseling, and timely consideration of advanced therapies. Fontan circulation provides survival for children with single ventricle anatomy, but it is not a cure. Over time, many patients experience progressive decline in function. The physiology depends on passive venous return to the pulmonary arteries without a subpulmonary pump, which means the system is exquisitely sensitive to elevated pulmonary vascular resistance. When pulmonary pressures rise or atrioventricular valve regurgitation increases preload, ventricular workload and systemic venous congestion intensify, accelerating failure. Complications are distinctive and often debilitating. Protein-losing enteropathy results from high systemic venous pressure and impaired lymphatic drainage, leading to hypoalbuminemia, edema, and malnutrition. Plastic bronchitis, though rare, is life-threatening, caused by leakage of lymphatic fluid into the airways and formation of obstructive casts. Thromboembolism is facilitated by sluggish venous flow, endothelial dysfunction, and arrhythmias. It is a major cause of morbidity and mortality. Arrhythmias themselves are common, reflecting atrial scarring, ventricular dilation, and chronic hemodynamic stress. The trajectory is highly variable. Some patients maintain stable function for decades, while others deteriorate in adolescence or young adulthood. Risk factors such as elevated pulmonary artery pressures, residual atrioventricular valve regurgitation, or impaired ventricular function at the time of Fontan completion predict earlier decline. These realities emphasize the need for lifelong surveillance and multidisciplinary management. The Fontan circulation should be seen as a delicate balance, vulnerable to disruption by even modest increases in pulmonary resistance or arrhythmia burden. Once decline begins, options include catheter-based palliation, surgical revision, or ultimately transplantation when medical therapies fail. Adults with congenital heart disease face a heightened burden of arrhythmias, both atrial and ventricular, which significantly shape long-term outcomes. Atrial flutter and fibrillation are especially common. The risk arises from atrial scarring created by surgical procedures, cannulation sites, and chronic pressure or volume loading. As patients age, atrial dilation and fibrosis amplify this vulnerability. The complications are substantial. Loss of atrioventricular synchrony impairs cardiac output, and thromboembolism, particularly ischemic stroke, becomes a major threat. Ventricular arrhythmias contribute to the risk of sudden cardiac death. Certain populations are at highest risk. In tetralogy of Fallot, a QRS duration greater than 180 milliseconds is strongly associated with malignant ventricular tachycardia and sudden death. Patients with atrial switch procedures for transposition and those with a Fontan circulation also have elevated risk, reflecting the combined effects of surgical scarring, systemic ventricular strain, and progressive myocardial fibrosis. The clinical impact extends beyond arrhythmia episodes themselves. Ventricular tachycardia and fibrillation often present late, with syncope or sudden collapse as the first sign. Atrial arrhythmias may cause insidious heart failure through loss of atrial contribution and rate-related dysfunction. In all cases, structured surveillance and early intervention, ranging from anticoagulation to ablation or device therapy, are critical to reduce morbidity and prevent sudden cardiac death. Adults with congenital heart disease face not only sequelae of their original lesions, but also an elevated risk of acquired cardiovascular conditions. Hypertension is particularly prevalent after coarctation repair. Even in anatomically successful repairs, up to 30% develop systemic hypertension later in life. Residual narrowing, abnormal aortic arch geometry, and intrinsic vessel stiffness contribute to this risk. These factors impair baroreceptor function and create abnormal vascular compliance, making lifelong blood pressure surveillance essential. Premature coronary artery disease, CAD, also emerges as an important concern. Adults with certain congenital lesions, such as those with a history of chronic cyanosis, prior arterial switch operations with coronary reimplantation, or inflammatory vasculopathy, demonstrate accelerated atherosclerotic risk. Chronic hypoxemia promotes polycythemia, endothelial dysfunction, and altered lipid metabolism, all of which predispose to early atherogenesis. Inflammatory processes related to prior surgery or altered hemodynamics may further exacerbate vascular injury. These acquired risks highlight a paradigm shift. Survival into adulthood with congenital heart disease now requires integrating preventive cardiology. Surveillance for hypertension and CAD should be routine, and aggressive management of modifiable risk factors is vital. Counseling must include not only congenital lesion surveillance, but also recognition that acquired vascular disease may present decades earlier than in the general population. Eisenmenger syndrome represents the final stage of uncorrected large left-to-right shunts. Persistent exposure of the pulmonary vasculature to high flow and pressure induces progressive structural remodeling and pulmonary arterial hypertension. Once pulmonary resistance exceeds systemic levels, the shunt reverses to right to left, producing cyanosis and irreversible physiology. The major risk factor is delayed repair of sizable defects, such as ventricular septal defects, atrial septal defects, or patent ductus arteriosus. Prolonged overcirculation during infancy and childhood accelerates pulmonary vascular injury, and once established, the hypertension is not reversible by surgical closure. Clinically, Eisenmenger patients experience progressive exercise intolerance, polycythemia, and complications of chronic hypoxemia. Right ventricular failure develops as pressure load rises, and sudden cardiac death is a recognized outcome. Multisystem consequences include hemoptysis, hyperviscosity symptoms, and increased risk of stroke or brain abscess. The only definitive prevention is early recognition and timely repair of significant shunts in infancy before irreversible pulmonary vascular remodeling occurs. Once Eisenmenger physiology is established, management becomes palliative, focused on symptom control, avoidance of hypovolemia, and selective use of pulmonary vasodilators. This complication underscores the critical importance of timely diagnosis and referral for surgical or catheter-based closure during the neonatal and infant period, since missed opportunities for repair carry lifelong consequences. Infective endocarditis remains a serious concern for certain congenital heart disease survivors, and risk stratification guides the need for antibiotic prophylaxis. The highest risk category includes prosthetic valves or prosthetic material used in repair, such as conduits and patches. Patients with a previous episode of endocarditis also remain at lifelong elevated risk. Unrepaired cyanotic congenital heart disease, or repaired lesions with residual shunts or valvular regurgitation adjacent to prosthetic material are likewise considered high risk. Surgically created systemic to pulmonary shunts, such as Blalock-Taussig shunts, also fall into this category. For these groups, antibiotic prophylaxis before procedures known to cause bacteremia remains recommended. In contrast, moderate-risk lesions no longer require routine prophylaxis under current guidelines. Bicuspid aortic valve is a common example. Most other congenital heart disease lesions that have been repaired without residual defects also do not warrant prophylaxis. The change in practice reflects evidence that endocarditis is rare in these populations, and that indiscriminate prophylaxis has little impact on overall rates. The key clinical point is that not all congenital heart disease survivors carry the same risk. Identifying which patients have prosthetic material, residual shunts, or unrepaired cyanotic physiology is essential to apply prophylaxis appropriately while avoiding unnecessary antibiotic use in those at lower risk. Prophylaxis is reserved for patients at highest risk of severe endocarditis. Current guidelines specify that antibiotic coverage is indicated for certain procedures. Dental interventions that involve manipulation of gingival tissue or perforation of oral mucosa are the most common trigger. Respiratory tract procedures that breach mucosa, such as tonsillectomy or bronchoscopy with biopsy, also warrant prophylaxis. Importantly, these recommendations apply only to patients in the high-risk categories already defined, not to all individuals with congenital heart disease. The preferred antibiotic regimen is oral amoxicillin, 50 mg per kilogram with a maximum of 2 grams, administered 1 hour before the procedure. For patients with a penicillin allergy, clindamycin is recommended at 20 mg per kilogram with a maximum of 600 mg. These single-dose regimens provide adequate coverage against viridans group Streptococci, the predominant organisms in procedure-related endocarditis. The critical teaching point is that prophylaxis is now tightly restricted. It is no longer indicated for most congenital heart disease survivors, but must be reliably provided for those with prosthetic material, residual cyanotic disease, prior endocarditis, or surgically created shunts. Preventing endocarditis in congenital heart disease extends well beyond procedural prophylaxis. Optimal dental hygiene is the most effective long-term defense. Regular dental care and daily oral health practices reduce the bacterial load and frequency of transient bacteremia, the principal pathway for viridans group streptococcal infection. High-risk patients should be counseled to avoid elective body piercings and tattoos, which create portals for infection and have been linked to bacteremia in vulnerable individuals. Early and aggressive treatment of infections, particularly dental and respiratory sources, is equally important. Any delay in managing abscesses, pharyngitis, or pneumonia can increase the risk of seeding prosthetic material or damaged valves. Patient education is central. Families and patients need to recognize the warning signs of endocarditis, including unexplained fever, new or changing murmurs, or embolic phenomena. Education should not wait until adulthood. It is best initiated in childhood, ensuring that adolescents and their caregivers understand preventive practices and know when to seek care. The emphasis is on empowering patients with lifelong strategies. Daily oral care, avoidance of unnecessary invasive exposures, vigilance for infection, and early recognition of symptoms. These measures collectively lower the lifetime risk of a devastating but preventable complication. Children surviving congenital heart disease surgery frequently demonstrate a distinct neurodevelopmental profile. Even when global intelligence testing falls within the normal range, deficits in executive functioning are prominent. Long-term follow-up studies in patients with transposition of the great arteries and hypoplastic left heart syndrome have shown persistent problems with working memory, attention, and academic achievement, despite survival into adolescence. Executive function encompasses higher-order skills necessary for adaptive behavior. Working memory impairments make it difficult to retain and manipulate information, affecting both school performance and daily organization. Cognitive flexibility is reduced, limiting the ability to shift strategies in response to new rules or challenges. Inhibitory control is also affected, leading to difficulty suppressing impulsive or inappropriate responses. Finally, planning and organizational skills are often weak, complicating the execution of complex or multi-step tasks. These deficits reflect the neurodevelopmental signature of complex congenital heart disease, thought to arise from a combination of abnormal fetal brain perfusion, perioperative injury, and genetic susceptibility. Studies consistently estimate that 20 to 30% of survivors experience clinically meaningful executive dysfunction, often requiring remedial educational services and structured support. The clinical impact is broad. Subtle impairments may not appear on early developmental testing, but become evident in adolescence when academic and social demands increase. This underscores the need for serial neurodevelopmental assessment and early intervention to optimize long-term outcomes. Neurocognitive challenges in congenital heart disease do not end in childhood. Subtle deficits often persist into adulthood and influence higher education, career progression, and independent living. Executive dysfunction, slower processing speed, and difficulties with complex planning remain common. Adults may complete school yet struggle with professional or social demands that require sustained organization and adaptability. Periodic reassessment, vocational support, and structured counseling help patients navigate these challenges and maintain quality of life. Attention disorders are significantly more prevalent among survivors of congenital heart disease, with rates of attention deficit hyperactivity disorder reported at 2 to 3 times higher than the general population. Importantly, the predominant presentation is inattentive type rather than hyperactive, making it more likely to be underrecognized in school settings. Difficulty sustaining focus and shifting between tasks contributes directly to impaired classroom performance. Academic challenges extend beyond attention alone. Mathematics has emerged as a particular area of vulnerability, with deficits in arithmetic skills documented across multiple cohorts of children with transposition of the great arteries and single ventricle physiology. Processing speed is also consistently slower than peers, reflecting both underlying neurocognitive inefficiencies and perioperative brain injury. Fine motor coordination difficulties further complicate academic functioning, impacting handwriting, drawing, and tasks requiring visuomotor integration. These patterns represent part of the broader neurodevelopmental signature of congenital heart disease. They persist into adolescence and young adulthood, often despite normal intelligence quotient scores, and can translate into repeated grades, need for remedial education, or limited vocational options later in life. Recognition of these risks early allows for targeted educational support and structured interventions that can mitigate long-term academic underachievement. Cardiopulmonary bypass is central to neonatal cardiac surgery, but introduces unique neurologic risks. Longer bypass times correlate with poorer neurodevelopmental outcomes, reflecting cumulative exposure to hypoperfusion, embolic events, and systemic inflammation. Deep hypothermic circulatory arrest, historically used to provide a bloodless field, was shown in the Boston circulatory arrest trial to increase early post-operative seizures and impair motor outcomes compared with low-flow bypass. Though some differences attenuated with age, both strategies left children below population norms on long-term testing, underscoring that neurologic vulnerability persists regardless of technique. Inflammatory cascades and microemboli generated during bypass further compound injury, contributing to white matter abnormalities frequently detected on post-operative imaging. Other perioperative factors have cumulative impact. Children requiring multiple surgeries sustain repeated exposures to bypass, anesthesia, and hemodynamic instability. Prolonged intensive care stays, often linked to complications or delayed recovery, are associated with higher risk of acquired brain injury and delayed developmental milestones. Chronic hypoxemia, either preoperatively due to cyanotic physiology or postoperatively from residual defects, alters brain maturation, with magnetic resonance imaging studies demonstrating delayed myelination and reduced brain volumes in infants with hypoplastic left heart syndrome and transposition. These data emphasize that neurologic outcomes in congenital heart disease are not determined by surgery alone, but by a continuum of exposures spanning preoperative physiology, intraoperative management, and postoperative course. Recognition of these risks has driven protocols for minimizing bypass time, monitoring cerebral oxygenation, and streamlining surgical timing to reduce cumulative injury. Neurodevelopmental outcomes in children with congenital heart disease are shaped by a combination of biological and social determinants. Genetic syndromes play a major role. Approximately 1/3 of children with congenital heart disease have an underlying genetic disorder such as trisomy 21 or 22q11.2 deletion, and these children demonstrate greater impairments in cognition, motor skills, language, and behavior compared with peers who have isolated heart disease. Prematurity adds an independent layer of risk. Infants born before 37 weeks with congenital heart disease face higher rates of brain injury and delayed development, as both conditions compound vulnerability to hypoxemia and hemodynamic instability. Socioeconomic factors also exert strong influence. In long-term follow-up of transposition of the great arteries survivors, socioeconomic status was one of the most powerful predictors of neurodevelopmental outcome, sometimes outweighing surgical or perioperative variables. Limited access to resources, early education, and supportive services magnifies deficits, while enriched environments can improve trajectories. Family functioning is another important determinant. High parental stress, poor coping mechanisms, and strained caregiving environments can exacerbate developmental difficulties. Conversely, families with strong support systems and effective stress management strategies foster resilience in children at risk. Crucially, many of these risk factors can be recognized during the neonatal intensive care period. Early identification of infants with syndromic features, prematurity, or psychosocial stressors allows proactive referral for developmental surveillance and intervention programs. This forward-looking approach gives families the tools and resources to mitigate long-term challenges. Children with congenital heart disease benefit most when developmental challenges are identified early. Regular developmental assessments beginning in infancy allow detection of subtle motor or cognitive delays before they become entrenched. The American Heart Association specifically recommends serial neurodevelopmental evaluations for high-risk groups, including those who required neonatal surgery, have cyanotic lesions, or demonstrate abnormal neuroimaging. Educational evaluations prior to school entry are crucial, since problems with attention, processing speed, or fine motor coordination may not be captured by routine pediatric visits, but significantly affect classroom performance. Comprehensive neuropsychological testing provides detailed profiles of strengths and weaknesses, guiding individualized educational planning. Early intervention therapies like speech, occupational, and physical therapy are effective when initiated promptly. For example, motor therapy improves coordination, while targeted speech services address expressive language delays that often emerge after complex heart surgery. Structured support in early childhood can alter long-term academic and social outcomes. Referral for early developmental screening should be viewed as part of standard care in congenital heart disease, beginning in the neonatal period. By embedding neurodevelopmental monitoring alongside cardiac follow-up, providers ensure that growth, learning, and functional independence are prioritized alongside survival. Mental health concerns are disproportionately common among survivors of congenital heart disease. Anxiety disorders occur at rates 2 to 3 times higher than in the general population. Medical anxiety often develops from repeated hospitalizations, invasive procedures, and the unpredictability of health status. Social anxiety is also prevalent, linked to visible scars, physical limitations, or feeling different from peers. Depression is another frequent complication. Chronic illness imposes restrictions on activity and lifestyle, often resulting in isolation, missed milestones, and reduced quality of life. Longitudinal studies demonstrate that adolescents with congenital heart disease have higher depressive symptom scores than healthy controls. The cumulative stress of lifelong follow-up, uncertainty about prognosis, and awareness of medical vulnerability all contribute to this burden. Post-traumatic stress disorder is increasingly recognized, traumatic memories of intensive care. Stays, surgeries, or emergent interventions can manifest as nightmares, hypervigilance, or avoidance behaviors. The effect is not limited to the patient. Families also experience medical trauma, further influencing psychosocial outcomes. The prevalence and persistence of these conditions emphasize the need for structured screening and early referral to mental health services as part of comprehensive congenital heart disease care. Addressing psychosocial health is not optional. It directly affects adherence, functional status, and overall quality of life. Educational attainment is frequently disrupted in congenital heart disease due to medical demands. Recurrent hospitalizations, surgical recoveries, and follow-up appointments cause frequent school absences, creating gaps in instruction and peer continuity. Even when present, physical restrictions, such as limited participation in sports or high-intensity activities, can contribute to a sense of exclusion. Peer relationships are often strained, with children reporting feelings of difference or isolation linked to scars, exercise intolerance, or developmental delays. As patients transition to adulthood, employment introduces new barriers. Physical limitations, including reduced exercise capacity or risk of arrhythmias, may constrain career choices, particularly in physically demanding fields. Insurance coverage remains a persistent concern for adults with congenital heart disease, given the lifelong need for specialized care and the financial vulnerability of those with chronic illness. Workplace accommodations are frequently necessary, such as flexible scheduling for medical visits or modified physical demands, but not universally available. These social integration challenges highlight that congenital heart disease is not solely a medical condition, but a lifelong influence on educational, social, and vocational opportunities. Comprehensive care requires anticipating these impacts, supporting families through school planning, and advocating for workplace protections as survivors age. Targeted psychological support is essential for children and families living with congenital heart disease. Individual therapy addresses the most common mental health challenges. Cognitive behavioral therapy has demonstrated benefit for anxiety and depression, helping patients reframe maladaptive thoughts and build coping skills. Trauma-focused therapy is particularly important for those with medical post-traumatic stress disorder, often stemming from intensive care admissions or repeated invasive procedures. Preparation therapy is another effective modality, teaching children strategies to manage anticipatory anxiety before surgeries, catheterizations, or transitions in care. Family interventions are equally critical. Family therapy acknowledges that congenital heart disease affects not only the patient, but the entire household. Structured sessions can improve communication, reduce conflict, and build resilience. Sibling support deserves special attention, as siblings often experience neglect of their own needs while care is focused on the child with heart disease. Programs that provide education and peer connection for siblings can mitigate feelings of isolation. Parent support groups allow caregivers to connect with others, navigating similar challenges, normalizing their experiences and offering practical guidance. The overarching principle is that psychosocial care must be integrated into the long-term management of congenital heart disease. Addressing anxiety, trauma, and family stress improves adherence to medical regimens, supports healthy development, and enhances overall quality of life.